Click all that apply. A training where learners gather 1 week for didactic presentations and the following week for in-person practical application. B, a training where learners complete a module online and later visited at their workplace by a trainer to discuss what was conveyed in the module. Then C, a program where learners gather in small groups for training and coaching. Before program completion, learners complete a series of Zoom calls to discuss further topics and questions. Please go ahead and take the poll. Marie, when it looks like most people have completed the poll, please show us the results.
Okay. We have about 65% of responses, and I'll end it right now.
Marie, I'll ask you to please take a moment and share those results. I'm unable to view on my end.
Here we go.
Okay. I recognize that about 56% of us have clicked that A is an example of blended learning. 83% of us are saying that B, a training where learners complete a module online and then gather together later on, confirm that is blended learning. Then a program where learners gather in small groups, 42% of us believe that that's blended learning or e-learning. However, with me, I'm confirming that the correct answers are B and C. Blended learning refers to the use of two different learning approaches, which we see in those two answers. In the first option, while trainees may be doing different things during the 2 weeks of that scenario, it is still in person and wouldn't count for our definition of blended learning. And it looks like many of us are agreeing that B is the option of blended learning. But I'm delighted to see that, again, some of us are considering C, a program where learners gather in small groups for training and coaching. And before the program is completed, learners complete a series of Zoom calls to discuss further topics and the questions. So let's go to the next slide and take a look at some other terms. So here, we have three general terms we'll hear a lot over this webinar. First, e-learning, which is learning facilitated by electronic media. Webinars, online modules, and entire online courses fall under this bucket. E-learning might happen live and involve some level of remote human interaction, or it might be as asynchronous and rely entirely on pre-programmed content. E-learning itself falls under the much wider category of digital learning, which includes things like interactive voice response and virtual simulation. That broader category of digital learning has a wider scope, but today we'll focus more specifically on e-learning. Next is on-site learning. This is what many of us who focus on provider capacity building are very familiar with, and is also referred to as in-person learning. On-site learning might be classroom-style learning or on-the-job training that takes place in the learner's workplace. It might be the presentation of slides or might be the facilitation of practical exercises. Either way, it is learning that takes place face-to-face. Finally, blended learning for the purpose of this webinar is the combination of e-learning and on-site learning. Blended learning encompasses both of the other two training methods listed here. You may also hear the term hybrid learning from panelists, a synonym for blended learning. Marie, next slide, please. So while on-site learning has been a long-standing default modality for health worker trainings, there are widely acknowledged challenges that moving to a blended learning approach may help address. The challenges include that fully in-person training is expensive for some programs, that human resources in terms of those who lead health worker trainings can be optimized if trainers were able to focus on content that can only be done face-to-face. If trainer time was optimized by leveraging blended learning, more providers could conceivably be reached. And finally, from a health worker perspective, on-site trainings, and particularly classroom-style trainings, interrupt service delivery. Clients miss out on services while their provider is away, and providers, particularly in the private sector, lose out on potential revenue. All three of these challenges we know could be addressed by e-learning. So next slide, please. So let us also take a look at what we know. What can e-learning add to the picture to address these challenges? In a moment, we'll hear from our 4 speakers on this question. And we hope to hear from you via questions and comments. But before we get there, let's take a look at some of the evidence that's gotten us this far. Momentum private healthcare delivery program carried out a rapid landscaping of the evidence, focusing on literature from 2018 onward that compares e-learning to on-site only approaches. As I share what's reflected in the evidence, it's important to note that most evidence to date comes from high-income country context, and that studies primarily compare fully in-person training to fully remote training. That is, there's limited comparison between blended approaches and in-person only approaches. And there's little evidence specifically looking at private sector providers in comparison with their public sector counterparts. That said, as I review more in the next slides, you see that enough evidence does exist to make it clear. E-learning, in a nutshell, is worth exploring. The first point that emerges, next slide, please. The first point that emerges from this evidence is that outcomes for e-learning and in-person learning are quite similar. It is clear that healthcare providers can learn through this modality. The majority of the evidence reviewed indicates similar results between e-learning and face-to-face training modalities for the healthcare providers specifically. A small number of studies have actually found better results for some outcomes in e-learning. However, one study found qualitatively worse knowledge gains in e-learning, so this isn't universal. Next slide, please. Training is also not a very dynamic activity, and the quality of a training can vary due to the number of factors, including the skill of the trainer. Important to note is that e-learning can't happen well without providers having enough available time, adequate connectivity, and up-to-date devices to access the training. An article from Global Health SP published last week also stressed the importance of post-training supervision. Next. Also important to consider is whether providers want to learn this way. Will they be motivated to take part in their digital trainings? Those are questions that remain with us. Several studies reported that trainees were highly satisfied and found that e-learning training useful or relevant in their practice, though in some settings, providers may prefer in-person training. In fact, learning may be preferred to both entirely in-person and entirely remote training. Healthcare workers tend to value the convenience and autonomy of e-learning combined with other benefits offered through in-person training. Next slide, Mary, please. We must also note that our literature also revealed a number of enablers and barriers to effective e-learning use. Enablers include making course design interactive, user-friendliness of the digital e-learning platform and course, self-paced formats, availability in preferred language, and endorsement of the e-learning content from trusted sources. Next, similarly, some barriers emerged, looking at the barriers now, some barriers emerged along the recommendations to address them. Difficulties with internet connection or inadequate digital literacy on the part of healthcare provider was such a barrier. Another were competing demands on healthcare time that reduced motivation to take or complete the e-course was another barrier. Several recommendations emerged to address these barriers, some of which our panelists will speak to directly in a few moments. Now, before we move into the presentation from the panelists, I want to ask each person on this webinar to call to mind their own experiences with blended learning as we answer another couple of quick poll questions. Marie, please you've already launched it. And again, I will read them out so that they are translated. Our first question: have you ever taken an e-learning course or participated in a blended learning training? It's either yes or a no. And in the second question, in a few words, how would you describe the experience? If you've taken the course before, in a few words, how would you describe the experience? Marie, I'll wait on you to let me know when it looks like most people have completed the poll, and then you can show the results.
Okay.
I believe we've all the translators already translated this. How is it looking like, Marie?
We have about 70% responses, so I can go ahead and end it now.
Okay.
And here are the results.
This is delightful. Seeing to it that clearly that blended and e-learning opportunities are becoming more and more common, with over 70% of us saying that we have participated in e-learning opportunities. I would like Marie to see to what people are saying about their own experiences.
Of course. So I see a couple of responses to the second question, describing their experience. I see one response is boring. Another response is, it was a good experience because I was able to access the learning materials at my place of convening without traveling long distances. More responses: I started the course at my convenience. It's self-paced and innovative. Convenient. Convenient seems like the word that pops up the most. The experience was convenient and allowed me to engage with peers around the world in a way that I otherwise would not have. Accessible, allows multiple interactions with participants, and a combination of both. Over.
Okay, thank you very much. Thank you very much, Marie. Like I said previously, it's clear that blended and e-learning opportunities are becoming more and more common, with many of us on this webinar having been a learner in such a model. And I recognize when we are talking about the different experiences, and convenience is sounding out as one of the critical benefits that we have had. Flexibility, as it's self-paced. But with all these questions, I'm going to ask that we keep our announcements in mind as we now turn to hear from our 4 panelists about their experiences, implement the different blended learning approaches for health workers. As you listen, please be sure to formulate questions for them. I encourage you to keep your own experiences in mind as we move ahead. So in the next few minutes, we are going to hear from our 4 panelists, each of whom will share brief details about a specific blended learning or e-learning experience. So we'll be hearing from Dr. Eze, a medical doctor and family planning master trainer with over a decade of experience in public health. Currently, Dr. Eze serves as a supporting lead for health system strengthening, a Society for Family Health, and has worked as a Momentum private healthcare delivery lead in Nigeria. He will share experience training providers to offer the hormonal IUD via blended learning. He will shortly be followed by Dr. Millie Kagwa, who is the acting head of quality and senior technical advisor for SRHR and MNCH at Population Services International. She's a medical doctor and a public health professional with over 20 years of experience. She will share Momentum private healthcare delivery experience, developing a set of FPRH e-learning courses, including feedback received directly from providers and related supervisors. She will then be followed by Safla Masare, who is a Deputy Chief Nursing and Midwifery Officer for the Sierra Leone Ministry of Health and Sanitation. She does have over 25 years of lived experience. She works with the Momentum Country and Global Leadership Project on building existing skills of midwives and nurses in Sierra Leone, and has been at the forefront of introducing e-learning for their continuing professional development. And lastly, we'll have Patricia Onwen, who is the Deputy Project Director for Farm Prep Project with JPEGO in Kenya. She has 12 years of experience working with HIV prevention, care and treatment programs and research, including training of healthcare workers, and will be sharing the experience of using blended learning to train pharmacists to offer and counsel on oral prep in Kenya. Before turning it over to Dr. Eze, I'll remind you all to please put your questions as you have them in the chat, and I'll be monitoring questions as we go along and noting them for our Q&A session at the end of the presentations. Now I'll turn it over to Dr. Eze. Dr. Eze, please.
Thank you so much, Lillian. So I'll be talking around the hormonal IUD blended learning, the work we did on the MPHD projects in Nigeria from the Society for Family Health. Next slide, please. So seeing the need to increase the options in the family planning method baskets, and of course, train providers in JOTPA method, the Society for Family Health through the R4S and LEAP projects, together with PSI and FHR 360, developed this e-learning content that enabled existing family planning providers who were already lab competent to integrate hormonal IUD into their service offering. So this was this curriculum was developed using a variety of learning resources like the TRP, the Family Planning Handbook, the lab manual from the Federal Ministry of Health in Nigeria, and of course, instruction and illustration videos from manufacturers like Bayer and M360. And then this e-learning curriculum was hosted on a learning management system. So after completing this training, participants were to be proficient in hormonal IUD counseling, insertion and removal. And then this training adopted a hybrid approach, so we had an online didactic component which took over from the traditional classroom style, followed by an in-person practical component to make sure the skills were actually adequate. And then the content was basically designed for healthcare workers who were family planning providers and already lab competent. And from the work we did on MPHD, this course took place in about 11 states in Nigeria. And Nigeria has about 36 states and the Federal Capital Territory. So 11 states out of the country was where this program was held, and it participating healthcare workers were doctors, nurses, community health officers, and then senior community health extension workers. These are people that were allowed to provide hormonal IUD services in Nigeria. Next slide, please. So what we did on the course was the trainees were actually added to a WhatsApp group, which served to, of course, provide our avenue for orientation and guide, for how to navigate the platform. And then they were later enrolled onto the course online. And then this course actually is 6 to 8 hour course if taken straight. But the trainees were given about 2 weeks to take this course, basically to allow for self-paced learning and, of course, knowledge retention. And after completing the didactic component online, these trainees were actually clustered, according to states, to have the in-person practical model, and then, of course, the supervised by master trainers to also have a competency-based clinical supervision with actual clients in their facilities, just to make sure that they were actually well qualified and certified competent to provide the services. So the course right now is actually open and available to be scaled. However, we're very conscious, to ensure that before anyone can be allowed to provide services on hormonal IUD, the person has also taken both the online component and, of course, has also been certified competent after a practical session with a master trainer. Next slide. Next slide, please. Okay, so what are the lessons we got from this intervention? So we understand strongly that one of the lessons we learned was involvement of the subnational ministries of health, in the states, in the training of private sector providers helped to bridge a lot of things. One of them was data gap, because data coming from the private sector was very difficult to get to the government. But when we involved the government in this, it helped to bridge that gap. And of course, it also ensures sustainability of the intervention. So the MPHD project has ended in our states, but of course, some of those interventions were still ongoing, especially around data. And then the development and the introduction of the WhatsApp platform and the Zoom calls was good for closer follow-up of the trainees, and it helped us to ensure there was high completion rate for the online courses. So these are very great lessons from the approach we adopted on the MPHD from Society for Family Health. Thank you very much. I'll now hand over to the next presenter.
Thank you, Dr. Eze. My name is Millie. Good morning, good afternoon, wherever you are. This work was completed under the Momentum Private Healthcare Delivery Project carried out by PSI, and it builds on the previous efforts that Dr. Eze has talked about. Under this activity, we developed a catalog of family planning courses available on the open source Kasai platform. Next slide, please. So after the development of the hormonal IUD e-learning course, we set out to develop a more comprehensive set of family planning courses to train healthcare providers. The courses could be completed either individually or even combined. And they serve as the didactic portion of training and are meant to be accompanied by a guided in-person practice. The courses could be used to teach new skills or as refresher trainings. The e-learning content was developed from widely available and vetted sources that are used for in-person training, such as the Training Resource Package, the World Health Organization Global Handbook for Providers, product manufacturers, training materials also from PSI and other leading partners. And MPHD's quality of care team developed some of the courses almost entirely from the ground. Others were simply rehoused or modified to be more interactive with e-learners as the target or intended audience. The newly developed e-learning courses covered hard and soft clinical skills for provision of hormonal IUDs, copper IUDs, implants, DPMA subcute, self-inject, and even contraceptive counseling. These courses are currently accessed via the open source Kasai platform, as I mentioned, and they can be accessed by anyone for free by creating an account and logging in. So while currently in Kasai, they were developed, while they are still in Kasai, they were developed using the Moodle software and can be hosted on any Moodle compliant platform. Next slide, please. So after developing these courses, MPHD fielded surveys with participants who enrolled in our first courses to go live, and that's the Counseling for Choice course and the Hormonal IUD course. The survey participants were private providers as well as 18 private sector supervisors. Next slide. Many of the questions focused on providers' preference for e-learning courses compared to other types of training methods. And the vast majority of our respondents shared that these courses were just as good as the traditional courses and of better quality. These e-learning courses have undergone a great deal of scrutiny in their development, and they have been designed to be comprehensive, to be clear, and to include engaging activities. Compared to in-person training that relies heavily on the skill of the individual trainer, we find that this is a more standardized approach that may lead to an overall better quality training. And the majority of the providers agree that these courses were convenient, they were flexible, and that they liked the self-guided aspect of the training. An interesting finding is that about 56% of the respondents say that they would prefer to learn new topics in person in future. When asked whether they prefer e-learning if it also came with per diems, 80% agreed that they would prefer e-learning. So that's food for thought. Next slide, please. as these e-learning courses were intended for blended learning, we look at the learner's confidence and readiness to engage in the next phase of the training, which is a hands-on clinical practice. Next slide. Next slide, please. Yes. So almost all the providers felt confident. They felt confident and ready to proceed to this next phase of the training, with the majority of the providers, supervisors also felt that the trainees were equally more prepared for the hands-on component compared to the typical learner. 29% of the learners agreed it would be hard to retain all the information they learned. And this percentage was higher for the hormonal IUD course, where providers were learning clinical or technical skills. Lastly, a substantive number of participants, 15 for the counseling for choice course and 38 for the hormonal IUD course, still have questions after taking the e-learning course. And this highlights the importance of a blended approach. There's much more I could present, but I need to turn to the next panelist. Over to you, Safula. Thank you.
Okay, sorry. Thank you, Millie. This is Safula talking on e-learning for midwives in remote areas in Sierra Leone. Next slide, please. In 2022, Momentum Counseling and Global Leadership under USAID introduced the e-learning platform to midwives in collaboration with the Ministry of Health and Sanitation, where nurses will use a platform online or offline to do their continuous professional development to enhance their profession. And Sierra Leone Midwives Association with the council, in collaboration with World Continuous Education Alliance, WCEA, had an access to mobile phones. Those who had access to mobile phones, online continuous professional development platform. And so more than 400,000 courses were online where nurses can access and do their courses and have their certification, which they can use for realizing and to develop their skills. And participants chose courses from emergency care, from leadership in nursing and midwifery, maternal health, obstetric care, etc. Next slide, please. There were a lot of, for us to start, there were a lot of consultative meetings where we had the continuous development content, which we have put together and included meetings from national level to district levels to health facilities. First of all, we had to have the usernames for the midwives when they were gathered together so that they will be able to access the World Continued Education as an education platform ahead of the national launch. We did national launch for the platform so that people could come together and do to access the platform. After the national launch, WhatsApp forums were created where nurses will easily share information, because that one is very popular over here. And then the M&E monitor and evaluation officers were trained so that they can help the midwives and other nurses to be able to access the platform. And as it was becoming very interesting, other nurses were now brought on board so that they can all access the courses and complete them. Next slide, please. No back. Lessons learned. Yes. Lessons learned from the rollout that midwives and nurses were highly motivated and interested to be enrolled for the courses on the WCA platform, because there were a lot of courses, as I've said, over 400,000 of different courses where they can go through and they build on their skills. And with the hands-on approach, participation was very exciting, and the participants became more interested as they were introduced to a series of courses on the platform. Although most of the healthcare workers did not have computers, but they had to do that one through their smart mobile phones. Those who had smart mobile phones, those who did not have, they went all out to get some. And where they can access the courses, download them and study at their own convenience. That became very exciting for them. And with the continuous professional development online, it can target a large scale of population of learners as compared to classroom-based learning which became very interesting for the nurses and midwives, because we needed this not only to build skills, but also for our realizing. Next slide, please. First 10 top certified courses. You have to go back one slide. First 10 top certified courses. Yes, this is the one. As you can see, topping the list, they are turned from the bottom. You can see about 230 of these participants did these courses successfully, starting from the HIV testing services to antiretroviral therapy for people living with HIV, monitoring and managing people on ARVs, specific interventions to eliminate mother-to-child transmission of HIV, advanced HIV care, respectful maternity care, management of normal labor, postpartum severe malaria, and introduction to WHO labor guide. It takes the ladder from down to up, as you are seeing, up to 230 of the midwives and nurses were doing these courses, and it was tapering down as we are going, as you saw the graph going above. But I want to thank you very much for listening. This is what we did in Sierra Leone. Over to you, Patricia.
Thank you. My name is Patricia. Next slide. So I'll start by giving a brief background of this work. So FarmPrep is an implementation science project that seeks to expand access to oral pre-exposure prophylaxis and post-exposure prophylaxis through private retail pharmacies in Kenya. So why was it necessary for us to develop this blended learning curriculum? So we were starting from a point where we had pharmacy providers who had not previously been trained on provision of HIV prevention services. In addition, there was no curriculum for these providers, and the curriculum that was existing that was meant for doctors and nurses required them to be away from their work for 3 weeks in order to complete. So as much as pharmacy providers were willing to offer these services, it was very difficult for them to close their businesses for this extended duration of time to be able to attend the trainings. Next slide. So to address this, we developed a blended learning pathway for pharmacy providers that had 3 components. The first component was where we had the online courses. We developed 2 courses. That is a course on post-exposure prophylaxis and HIV testing services, the e-learning courses. And we developed this from the content from WHO and also the national guidelines, so the national training curriculum. We also added an existing curriculum on a pre-exposure prophylaxis that had previously been developed by JAPIGO in collaboration with WHO and was existing on the WCA platform. So after this, we hosted all these 3 on the WCA platform, and the providers were to conduct these courses at their own pace, and we gave them a period of around 2 weeks to complete. In addition, these courses were CPD accredited, and the participants would get certificates of completion when they completed all the 3 courses. This was followed by a 2-day in-person workshop where we required the participants to present their certificates just as evidence that they had completed the online content. The purpose for the in-person workshop was to reinforce the content that had been presented through the e-learning. We were also reviewing the study procedures and logistics, given that this was a study. This also offered an opportunity to have practical sessions, especially on HIV testing services and counseling. Upon completion of this 2-day workshop, which we did initially, for the other participants that we onboarded later, these workshops were being done on job at their place of work. This was followed by a 1-day observed practice where each of the participants was required to test 3 clients at a real HIV testing service delivery point in a public health facility under the supervision of Ministry of Health trainers. Next slide. So we received a very good feedback from the participants, and we can see some of the feedback displayed here. So most of the feedback was around how the content was, how the course was organized, the order of the course, and even the presence of the links, that they would refer to later. And they also appreciated this new way of learning. And they were able to, they also appreciated, the pre-test and the post-test that made it more interesting, and also how the content was presented. Next slide. So on this slide, on the right, we present some of the scores, the pre-test and post-test scores for each of the courses. And you can see there was significant learning for each of the 3 courses that were offered. This is specifically for the e-learning. What did we learn? From this, we learned that given our context, blended learning approach was the best. It was actually more preferred to pharmacy providers over the traditional curriculum that would have required them to be away from their work for an extended period of time. We also learned that a one-off training is not enough, and it is important to continue offering ongoing support to their providers at their workplace. Lastly, the CPD points that were awarded upon completion of the course was a big motivator for the pharmacy providers to complete the online training. Thank you.
Blended learning challenges. I've been trying to unmute myself for a while and it took me a long time. I want to say a very great thank you to our panelists for giving us a glimpse into their experiences with e-learning. As you have heard, we have a wide array of e-learning and blended learning examples. We have heard about use of e-learning to teach a clinical family planning skill from Dr. Eze. We have heard about developing courses from scratch for global use as global products from Dr. Millie. We have heard about training midwives on key competencies from Safula, and about e-learning with pharmacists offering HIV prevention products from Patricia. We are now at the moment where we'll begin opening for our fireside chat. If you haven't already done so, please put your questions for our panelists in the chat. Be sure to note who your question is for. I'll give you a moment to do so. But before getting started with the Q&A for the panelists, I also have one last set of 4 questions for you, the participants. As you formulate any question for the panelists, please also answer the questions about your own thoughts on e-learning as you see them come through in the poll. Like we've done before, allow me to read them, to read them for the translation. But remember, these questions, there's no right or wrong answer. So feel free to submit. Our first question is, how would you feel receiving a service from a health worker trained via blended learning? We have options. We have A to D for us to select. I would feel entirely comfortable. It wouldn't make a big difference to me. I would not want to visit this provider, God forbid, or I'm not sure. Then our second question, in a few words, what would make you feel comfortable receiving a service from a provider trained by blended learning using e-learning? Marie, over to you. Let me know when we have most people responding, and then you can show the results.
Okay. We're about 20% right now.
Okay, we'll give it time. As we wait for everybody to respond, please know that we appreciate your participation on this webinar and learn and hearing from your thoughts and your experiences and your comfort in receiving a service from somebody who has been trained using these varied approaches is relevant to improvement of the programs that we have. So kindly feel free to input. Marie, when we have about 50% responses, please feel free. Please go ahead and read for us what is coming through.
We're almost there. 45% right now. Okay, And I will end it now.
It's very good to note that over 50% of us would feel entirely comfortable receiving services from somebody or from a health worker who has been trained using this a blended approach. It's also good to note that 30% of us wouldn't make a big difference to me as long as the person is trained. It's even further delighting to learn that none of us would not consider visiting the provider. So regardless of their training mode approach, we would still visit them. But we have some people who are 11% who are saying they're not sure. Again, we continue to learn about the benefits of having people trained or health workers trained using the e-learning approach. I'm going to ask you, Marie, to read out a few of the commentary that's coming through about people's experiences.
Yes.
The last question, please.
Of course. So we have a comment that says, I would not know if someone is trained. And next we have, because the content is the same and as much as certified to have passed, it's okay with me. Another comment says, I sometimes feel like the health worker can lack some knowledge, especially practical knowledge. With blended learning, using e-learning makes learning effective by experience sharing.
Okay, thank you very much, Marie.
Yeah.
I want to say thank you to all of us for your thoughts. It is interesting to once again see the perspective on e-learning, particularly the one on I'm not sure, but also to note where people say it doesn't really matter. And with all of this in mind, your own experiences and perspective on e-learning, plus all the rich expertise that we've had from the panelists, let me move quickly into the open discussion. We have about 10 minutes, about 8 minutes for this. So I will quickly jump in and pose this question to both Dr. Eze and Patricia. You both spoke about work conducted within a mixed health system, but that focused on the private sector. So what made working with the private sector unique? And what role did government play in the design, rollout, or other steps in your work? Perhaps we hear from Patricia and then Dr. Eze in just a minute, please.
Okay, thank you for that great question. So to start with, what made working with the private sector unique? I think this was a sector, or this was a population or a cadre of providers that was looking forward to something different, because the traditional training approaches usually require them to leave their businesses, and this means revenue loss for them. So when we presented this approach to them, I would say they were very enthusiastic to take it because this was a newer approach that would not require them to close their businesses for an extended period of time. To the question on the role of the Ministry of Health, so it was very important for us to collaborate and get buy-in from the Ministry of Health from the beginning. So when we were developing the curriculum, we had discussions with the relevant departments within the Ministry of Health. And as I mentioned earlier, the curriculum that we developed was actually adopted from the national curriculum together with the WHO curriculum. So part of their role was first for them to allow us to develop this, and also for them to review the curriculum before we took it out to use it for these pharmacy providers. Thank you.
Dr. Eze, please.
Thank you so much, Lillian. In Nigeria, over 60% of family planning services are provided in the private sector. So it's actually a huge place where these services can be provided. And most interventions, are actually targeted at the public when it comes from government. So we have this array of opportunity for you to work with the private sector, but was not really coming. So the MPHG project provided that clear opportunity for us to work with the private. And of course, the uniqueness is not far from what Patricia just said. Yeah, because it's profit oriented, so you don't expect, and they don't usually find it easy to allow their staff to go out, for long and of course continue doing their work while being trained. So I think that also was one of those key selling points for us. And of course, the government was instrumental in everything. Of course, following the hormonal IUD introduction and scale-up plan that was developed way back in 2021, master trainers that were trained in all the states. So utilizing those state master trainers for the trainings on MPHD, like I stated in my presentation, supported sustainability of this activity. So the government supported all that because they made it possible, the enabling environment, the documents used for the development of the tool, which they were part of, was coming from the government. So that uniqueness around the private sector providers was very clear out there.
Thank you very much, Dr. Eze. Just before you leave the stage, there are a number of questions that came in in the chat that related to ensuring participants get to practice the skill that they've learned via e-learning, or about any follow-up support. So how would you assess how the participants of e-learning courses are able to put the new learning into practice?
Yeah, so what we did was, first of all, after the digital training was concluded and providers were clustered, what we did was we assigned these various trainees to specific master trainers whose duty was to blend this into their state curriculum or state routine supervision. So each state has an integrated supportive supervision and strategy with which they go to supervise the public sector facilities. But seeing that we blended this into the strategy from the onset, some of these private facilities have supervision from the states, from the state government to follow up with their skills at the end. We didn't just stop at just the competency follow-up, but we ensured that these providers were followed up as much as towards proficiency. And that helped the states more or less to get those data that were sitting or lying fallow in those facilities up to the states for capturing to the demographic health information system. So I think that was a big win for us in that light.
Thank you very much, Dr. Eze. I think it's important for us to hear from another experience from Sierra Leone. Safula, do you mind telling us quickly how you are able to assess how the participants of the e-learning courses, the midwives and nurses, are able to put the new learning into practice?
Yes, thank you very much, Lillian, and all listening. For us in Sierra Leone, people are worried, but what we do after the e-learning, after the certification, people have the opportunity to also practice the skills. And as of now, we stand to include in our mentoring, because mentoring and preceptorship programs are ongoing. We intend to now incorporate them into the mentorship process, so that all these courses which are being collated by the manager and evaluation officers, we have mentors in the facilities who will go out to see how these courses that the midwives and nurses have learned are being put into practice. But as I speak now, most of them are in their facilities also doing these courses that they have training, because their skills have been developed, and because they saw that they were lacking in these skills, that's why they have been accessing them online. So now for those reports coming from their areas, they are the ones who are now doing some of these procedures, also counseling the clients and doing all the great work on it. So once we incorporate it, get feedback from them, and then mentorship can be done on these processes, so that when the feedback is what we can now see. Before now, why we could not do much, because we are still rolling out, and we have enrolled so many midwives, and we are covering more districts as from the last time. So this is what we intend to do. And as of now, their skills have been upgraded, and they are actually proving themselves in their area of study. And that is why it has become very interesting and exciting.
Thank you very much, Safla. It's good for us to hear for the different perspectives from the different countries. But Patricia made a presentation bringing a different kind of healthcare providers. And so, Patricia, what factors do you think need to be considered differently when working with pharmacists, as an example?
Okay, thank you. So I would say from what we have learned, one thing that is required is flexibility, because despite providing a time within which they were supposed to complete their online training, you find that they have a lot of competing activities. Some of them are running these businesses and working elsewhere. So due to these other competing priorities, sometimes they may not be able to complete the time, the courses if the time provided is short. So it's really, really important to be flexible and just, provide, more time for them to complete the online training. And I think the other thing, like I mentioned, if they are doing these courses and it adds something in their professional development, like through the CPD points, I think that is also something that is important, and also awarding certificates. These are things that they value, especially if you're talking about training. So as they go for this training, you want to build their capacity. They also need to feel like there's something else in it for them, apart from just building their capacity. Thank you.
Thank you very much, Patricia. And as we wrap up our side chat, allow me to pose one last question to Dr. Millie. Dr. Millie, we know that we can have participants who have never had any experience in the e-learning coming and for the first time attending our trainings. So what about using blended learning for fresh participants, like those that have no prior experience in relation to the topic being taught? What has been your experience?
Great question, Dr. Lillian. Again, some of the courses, for instance, especially clinical and technical ones, definitely need someone to have had some prior experience, at least with the family planning. So, for instance, it is getting a completely new person who doesn't even have any idea about anatomy to study the hormonal IUD course might be a little difficult. But when it comes to other courses, such as, for instance, the counseling for choice course, which is a little less, it's not very technical, it's not really clinical. This is one where even learners who have not had prior experience or exposure to these materials will definitely benefit from the content. So I think it is pretty much dependent on what the course is, what is the actual topic or the course that you're actually you have in the e-learning, and that will determine the kind of that will determine whether a completely new non-experienced person really take that and benefit from that course. Thank you.
Thank you very much, Dr. Millie, and thank you very much to our panelists who have been able to respond to the question, and thank you for the participants for the questions you've posed in the chat. We have 1 minute left, and I'm going to kindly ask that we stay on for another 5 minutes so that we can conclude our webinar discussion today. So with just 1 minute left, I'm going to ask each panelist to offer any final brief reflection, if they like, perhaps sharing your perspectives on what the future of capacity building for health workers will be, particularly considering e-learning. 1 minute, Dr. Eze, please.
Thank you so much once again, Lillian. And I think with this approach to capacity building that's around a blended approach to trainings, I think this provides a very good cost savings means to train at scale. Currently, what we are seeing now is that governments and states are beginning to see the need to key into this aspect of training, because it helps to train at scale, even in very hard to reach areas. And again, combining that with now, the time spent, ability to have retention, even after the course has been taken for a while, participants can still go back to get refresher. I think everything boils down at ensuring that skills are maintained, knowledge is retained, and again, the confidence of providers are built. So I think it's a good thing that is coming on board. And we are seeing that a lot of people are showing interest in using those tools to train. It's something that not only will it be beneficial to hormonal IUD, but we see that as it's currently being expanded to other family planning methods. I think it's a good way to go to ensure that skills remain optimal. Thank you.
Thank you very much, Dr. Eze. Over to you, Dr. Millie, in 1 minute. Please tell us about the global perspective on this.
I think this going forward, and my one last final thought on e-learning would be that if you're looking at, as the Minister of Health, you're looking at a standardized approach to training. This is one way of achieving it. It's cost effective, as Dr. Eze has said. And also for the part of the participants, we talked about flexibility, and those are things that flexibility, time, self-directed, and those are things that are important for providers. Thank you.
Thank you, Dr. Millie. Over to Safla for the nurses and the midwives and the Minister of Health.
Thank you all of you for Sierra Leone Midwives are taking center stage. As you all know, we are trying to reduce our high level of maternal mortality. So building capacity of midwives in this way has been a welcome idea, even from the government, because they are also very busy all the time. So doing the courses at their own level, with their own pace, in their own convenience, is something very good. And so we want to continue in this space. We want sustainability in this area, even after funding may have gone away. And what we want is that government makes it a policy so that this all can be considered, because we need to produce evidence for us to be realizing to continue to practice. So if policies are made and government takes over some of the responsibilities to help all those who are in very remote areas so that we all can be on one pace, will be a very good one. That is why we hold USAID Momentum and the Momentum Global Country Leadership Program very high, because they have helped midwives. Thank you all very much.
What a way to finalize. And finally, over to you to Patricia, please.
Thank you. So my final reflections are that as we talk about differentiated service delivery and task shifting to expand services, blended learning is the approach that will help us get there and build a critical mass of a trained workforce to be able to offer these services. Thank you.
Thank you very much, Patricia. And a very heartfelt thank you to all our panelists, Dr. Eze, Dr. Millie, Sapla, and Patricia. Thank you for sharing with us today. And before we let you all go, on the screen now you see a number of resources, and these will be in the chat. The first two are items mentioned over the course of this webinar, the training resource package for family planning, and the two different e-learning platforms, WCA and Kasai. The second couple of documents are the other related resources you may find helpful in your work on blended and e-learning activities. A guide, Momentum, produced for those planning to run distance and blended learning programs, and those with a high impact practice enhancement document on digital health to support FP providers, which includes sections on digital health for provider trainings. And with that, I will say a final thank you to all of our panelists and all of our participants. Thank you very much, and we do appreciate your participation, your engagement, and the interesting discussion. Thank you all, and have a wonderful day ahead. Thank you very much.